Muchas gracias, Luis. Gracias por invitarme. Yo voy a hablar en inglés. Pido perdón porque no tuve tiempo para traducir mis slides y están en inglés. Si leo en inglés, pienso en portugués y hablo en castellano, es una confusión. Entonces, voy a hablar en inglés, pero contesto las preguntas en español. Estos son, those are my conflict of my disclosures, and I'm going to put that little man sometimes just to say that this is my personal opinion. Because sometimes we don't have enough data. And so that's my interpretation that might be wrong. And this is the outline of my presentation. And the first thing is that initial treatment with 2 nucleosides and 1 first-generation NNRTI is very frequent. Guidelines nowadays start treatment with second-generation integrase inhibitors, but nonetheless, we have many, many patients. Look at the Brazil example. We have right now, 2021, 700,000 patients on treatment. Look at this, 2021. We have 19% of patients being treated with tenofovir 3TC and efavirenz. Plus, among those 12% of patients, we have also nevirapine and AZT 3TC efavirenz, more or less 6%. So we are going to have 25% right now in Brazil of 700,000 using first-generation NNRTIs, and this is the world. No matter if it's a rich country or a poor country. And what we need to know if we have an interruption of efavirenz or nevirapine, this is going to be resistance. This is an important concept, especially because during COVID-19, we have many, many patients that lost to follow-up. Why that? Because resistance comes in monotherapy. And as we have a very large half-life of nevirapine and efavirenz, this is going to be monotherapy upon interruption. So we need to interpret this as a resistance to NNRTIs, even if you don't see this. And we have the prevalence or the incidence of resistance in the clinical trials. So if you look the clinical trials with efavirenz and nevirapine, this is the picture. Once you have a failure, 50% of patients, you have NNRTI mutations. If this is efavirenz, this is going to be K103N. And 25% is going to have resistance to 3TC or FTC. That's M184V. And always, this 25% is inside this 50%. So 50% of patients will not have resistance. This is not what happened in the real world. And I'm going to show you. First, this is our data in Brazil. We get a very large number of patients, almost 3,000 patients failing efavirenz or 255 failing nevirapine. And look at this. Only 18% do not have resistance. What was 50% in the last slide, it's 18% more. If you look at this is NNRTI resistant efavirenz, nevirapine is the same. So I told you that 50% will have resistance to efavirenz, but in Brazil, it's 7-8%. More, 25% in clinical trials, we have M184V, and here is 58%. And more, we have resistance to tenofovir, abacavir, DDI. It's here, more than 35%. This is 0 in clinical trial. So we need to expect more resistance. And when we are going to do a salvage therapy for an NNRTI failure, we need a backbone, is a very potent and high genetic barrier drug, and something else. And this was done in NADIA. NADIA is a very smart randomization, 2x2 factorial randomization. First randomization, patients failing efavirenz with tenofovir are going to be either in dolutegravir or darunavir. Second, we are going to see if AZT is needed. So the second randomization is using tenofovir, they were failing tenofovir, or AZT. Why that? Because the K65R mutation from tenofovir will give resistance to everything, every nucleoside analog, but AZT. Then, just to confirm that resistance is very prevalent, look at this. Half of the patients will have the K65R mutation. And almost everybody is going to have the 3TC FTC resistance. The results show, it's like this. You have this line. If you go to the left, darunavir is better. If the point is going to the right, dolutegravir is better. But if the confidence interval cross the line, it's the same. So we can see this is the same. Dolutegravir performed as well as darunavir. With tenofovir, zidovudine, this is interesting, the resistance. If you have 0 nucleoside, active nucleoside, it's better than if you have 1 or 2. If you have more resistance, it's better. We saw this in other studies. Because resistance to nucleoside is a marker of adherence. If you don't take the meds, you're not going to have resistance. If you're not adherent, you never will be, perhaps. So, if you have some levels of resistance, you are going to have a good performance. So, you need the backbone, plus the residual activity of tenofovir or AZT. And we don't need AZT. This is the slide, the same thing. The line, if you go to the left, AZT is better. If you go to the right, tenofovir is better. And if you do not have good adherence, tenofovir is always better. Otherwise, it's the same. It's like this. K65R absent, bad adherence. Tenofovir is better. M184V absent, bad adherence. Tenofovir is better. The same as tenofovir resistance. So this is a good news. We can salvage tenofovir failure with tenofovir, and you don't need AZT. The other thing, we cannot use NNRTIs, first generation NNRTIs, or second generation NNRTIs, or first generation INSTI, like raltegravir. We saw that. Those are patients failing nevirapine and efavirenz, and they have mutations, but they are sensitive to etravirine, second generation NNRTI, and that's the vocation of etravirine, to be active with resistant to nevirapine and efavirenz. So this study just randomized patients to either receive etravirine or boosted PIs, and it was not good for etravirine because probably you have resistance to the nukes, and we have to interrupt the trial. Same thing with the benchmark. The lesson is, if you are using, in this study, you have viral load below detection limits with lopinavir. Half of patients were randomized to go to raltegravir, and they failure. And if you look with a magnifying glass, patients that failure to raltegravir in the switch study had evidence of resistance to NNRTIs. That's the point. And now we have Biktarvy. Can we do a salvage therapy for those patients with Biktarvy? There is no such a trial. There is no clinical trial registered using Biktarvy as salvage therapy. And maybe Biktarvy is not that potent as dolutegravir. Potence is an added value of the dose-finding studies. So you give monotherapy, and at some point, you increase the level of the drug, and it's not going to decay the viral load, like this is Maraviroc. So you use the lower doses with the more potent viral load decay. When you look at the dolutegravir, this is 2.4, almost 2.5 log decay. If you look at bictegravir, it seems the same, but no, they use the doses that is going to decrease only 2 log just to mitigate side effects. So we don't know, but maybe bictegravir as a backbone is not that potent, and we don't know if this is going to be good for salvage therapy, although with NNRTI or other mutations for first line, it's good. And what about 3TC with another drug, dolutegravir or boosted PI? With boosted PI, it's okay because it's safe. You're not going to have resistance, probably. But with dolutegravir, well, if patients are naive to integrase inhibitors, this is a good news because we can have dolutegravir as monotherapy in detecting 91% of the virus. This is in the Domono study. 95 patients, after 1 year, only 8 with viremia. 3 of them with resistance. But that's the point. In monotherapy, dolutegravir is able to go below detection limit for 91% of patients. So, if you use dolutegravir with lousy NUCs, maybe it's going to work, like we saw in Nadia. And perhaps, if you use a less potent scheme, we can succeed. Just to finish, INSTI failures, first generation INSTI failures, raltegravir has 3 pathways of resistance using codon 155, 143, and 148. 148 has cross resistance to dolutegravir. It's what we see here with the fold change, higher fold change to 148 mutations, so we cannot use. In Brazil, we can see that upon raltegravir failure, we have many patients with the bad pathway, 148, in red here. But maybe this is not a problem, because this is not a very prevalent scheme. People are not going to fail raltegravir at first-line regimen, and if they do, you use boosted PIs. But what about dolutegravir or bictegravir? Well, in clinical trials, if you use 2 nucleosides and second generation INSTI, you have no resistance. This is the bictegravir trials, just showed in the last conference. If you get the arms of bictegravir in 2 trials, and you see 240 weeks of treatment, it performs well and more. There is no resistance. It's the same as dolutegravir. In clinical trials, you have no resistance if you are failing a first-line regimen. But if you use 3TC and dolutegravir, a less potent scheme, you have 2 cases of resistance. One in Gemini, and other in the ACTG 5353. The patients are here. So in the Gemini, 2 drugs performed as well as 3 drugs. And this is the patient. NNRTI at week 132, viral load high, bad adherence. Then the 263 mutations appear. Same thing with ACTG 5353, NNRTI, then 263. And look at this. The fold change, that's the phenotypic resistance, is low. Should be high, but it's low. Perhaps because we do not know how to look at resistance to integrase inhibitors. The genotypic correlates of resistance to INSTI are not completely elucidated, and therefore, we do not have perfect phenotypic assays. I'm going to show you. This is our paper in Lescroix. We have mutations outside integrase that give resistance. This is the 3' PPT. This is NAF gene. So we get 51 patients failing dolutegravir, many of them after raltegravir, and 6 of them have resistance that we cannot see in our regular genotype tests. Half of them were pre-exposed to raltegravir, and only 1 have the integrase mutation. Therefore, we are not looking at this in our genotypic assay, and we do not include this in the phenotypic assay, this part of the genome. And I told you about the clinical trials, no resistance to Biktarvy or to dolutegravir. Bictegravir, ask Luis. But dolutegravir, ask me and Mauro. We have this study, first-line failure, 113 patients in Brazil, and we see mutations. It's called on 118, 138, 263. So those are major mutations to dolutegravir, and many with other mutations at the integrase. We have evidence of transmit drug resistance among those patients, and our hypothesis is, if you have transmit drug resistance plus bad adherence, you may have failure because you let dolutegravir in monotherapy sometimes. You have 2 pills. Then you may select resistance to dolutegravir. That's the hypothesis. So if you are failing 2 nucleosides and second-generation INSTI, and you have no mutations, maybe it's just an adherence problem. Enforce adherence, and you can salvage INSTI using the same INSTI. We saw that before. Otherwise, we can use boosted PIs. Just change the backbone. Or you take out the nukes. In the guidelines of Brazil, we use dolutegravir and darunavir with ritonavir in those cases as well. We may choose. In some patients, we have that low level of viremia with no resistance. And Brazil is the place that has more dolutegravir in the world, so we are going to see everything there. And for those patients, maybe this is toxicity, because for some of them, we just take out one of the nukes and viral load went below detection again. So how to explain that? Maybe it's tenofovir toxicity, and this is the conclusion. We need to learn from the clinical trials, and we have to understand better with real life. Thank you for your attention.